Okay, ladies and gentlemen, could we settle down? Could we settle down? We're going to start with our next segment now actually, since I'm on stage. I hope you all had a good lunch, and I hope you all enjoyed that first half of the conference that we've had so far. So this is the halfway mark, and at this point in time, I have to thank again our sponsors because they've supported this very, very strongly. I'd like to acknowledge our sponsors and our exhibitors, 26 of them altogether, who are supporting us today, especially ST Healthcare, Salesforce, and NEC, and also Tag Industrial as well. All right, let's move on now and let's get the next segment going. The next segment, as we know, is about redefining impact. But we've got a bit of a surprise for all of you right now. Without spoiling the surprise too much, I'm going to introduce to you a slightly unusual, slightly probably crazy bunch of people that are going to get all of us to think and maybe sing at the same time, all right? So let's welcome Alvin and Pradhan Sayang.
Thank you. Hello, hello.
Hello, everyone.
Thank you.
Hello.
So nice to see all of you. I hope you all had a great lunch. Let me introduce ourselves. On my right, I have Joseph.
Hello, everyone. Nice to be here.
And next in blue, our Nyonya, we have Rita.
Hello, everybody. Good to be here.
And our banana bright sunshine yellow, we have Jackie.
Hello, good afternoon, everybody.
And my name is Alvin. You can clap for me, it's okay. Okay, so earlier on you all had the scaling impact, right? And we're just here to reinforce the morning session. And we're going to do some scaling ourselves by doing some musical scales. So we're going to get everybody a little warmed up with your voices. So let's show them the slide. We're going to do the C major scale, okay? So we're going to get everybody to sing along from Do all the way to Do, Re, Mi, Fa, Sol, La, Ti, back to Do. Okay, are you guys ready? Wow, very enthusiastic.
Everybody.
Are you ready?
Yay!
Ah, that's better. So we're going to start with Do. At the count of 3. 1, 2, 3. Do.
Not bad.
Louder. One more time. Let's try Do one more time. 1, 2, 3.
Do.
Okay, let's do Re. 1, 2, 3. Re. Louder. Mi. Come on. Fa. So. Louder. La. Ti. Last one. Do. Wow, give yourselves a big round of applause.
Yay!
Fantastic.
Wow, voices all warmed up now.
Okay, we have done our job. You've done your scales. No, it's not over yet.
Yes.
Okay, so that's too simple. That's really too simple. So we're going to do something more challenging. Joe, what do you think?
Yes.
Okay.
We are going to make you choirs.
A
Yes.
choir.
Since, this auditorium is really divided into 3 segments.
Yep.
We are going to have 3-part choir.
Wow.
So the center part, the left side from your perspective, the right side, and then this side. So 3 of you will be learning something different.
Yes.
Because it's part of scaling, actually, right? Because each one has different degrees of challenges.
Yes.
Right.
Okay.
And the song we're going to pick to help you do this is
A very popular song
Not very
called
popular.
Everyone will
Stand
know
By Me.
Stand by me.
Yes, you all know the
Okay, so
song?
it's simple.
Everybody, yeah?
Yes. I know you're sitting down, but Stand By Me.
It's okay.
Okay, so we're going to teach them. So you guys are going to do the oohs, right?
Yes.
This one.
Middle section will do the ooh.
This side, you're going to do the...
The shalala.
You're going to do the
Shalala.
shalalas. You're the shalala.
You're the
Shalala.
shalala.
And
this
this
side?
segment will do the doo-doo.
You're the doo-doos.
Doo-doos.
Doo-doos. Okay. So let's try. We're
Yeah,
going to have
okay.
some music.
Can we have our mics louder?
Don't be afraid to sing, okay? I know some of you only sing in the showers. Pretend you're in the shower.
Okay.
We won't look at you.
Can we have mic
Can we have mic
6
1 and
that's
6
slightly-
louder?
Okay, it's fine. Thank you.
Thank you.
Okay.
So this segment called Scaling Together Challenge, right?
Okay. So let's do this.
So here, this is music, right? So middle segment, we're going to do this, your part. I'm going to sing once, you're going to follow after me. You count to 4, then you come in at 1. Okay? Like 1, 2, 3, 4. Go up. Your turn. 1, 2, 3, 4. Very good. Now we're going to do the shalala part, okay? So your part is,
So remember, yeah?
yours is 1, 2, 3, 4, 1. Then you come in, okay?
Let's show them on screen, the shalalala. Okay.
Okay, here we go. Your shalala. 1, 2, 3, 4, 1. Shalalala. 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 Up.
Higher.
Shalalala. Up.
Higher.
Shalalala.
Go down.
Shalalala. Your turn. 1, 2, 3,
Let's hear
4,
you.
1. Shalalala. Shalalala.
Behind.
Shalalala. 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 Shalala. Well done. Now
Very
the third
good.
group.
Good.
You
Keep
have
it
to
there.
take the
The
third
doo-doo.
group. Yeah.
Alright.
Okay, you're the
You also
doo-doo.
1, 2, 3, 4, 1. Okay.
Doo-doo.
Yeah.
You're the doo-doo.
The doo-doo.
Doo-doo.
Doo-doo doesn't mean toilet. Okay, it goes like this.
1, 2, 3, 4, 1.
Doo-doo. 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 Doo-doo.
Up.
Doo-doo.
Down.
Doo-doo. Everybody? Doo-doo.
1.
Your turn.
Go. 1.
Doo-doo. Doo-doo. Doo-doo.
We're going to do all together
Doo-doo.
now, okay?
Doo-doo. Doo-doo. Doo-doo.
Everybody. 1, 2,
Doo-doo.
3, 4. Ooh. Shalalala. 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 Up. Shalalala. Up. Shalalala. Shalalala. One more time. 2, 3, 4. Ooh. Shalalala. 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 Very good. So what we do? We're gonna
Very
do the
good. Give
song
yourselves
now.
a big round of applause. You guys are very good.
We're going to sing the song now. Okay?
Okay, so we're going to do the whole song, but you
Entire
guys got
song.
to join in. All right?
But we're
And-
going to join in the chorus. All of you will join the chorus, and
Okay,
the chorus
so at
is
the
up
end, the
here
chorus,
for
you all sing along. All right? So we're going to try this. We've never done this before.
Yes.
First time.
So this is your pattern. Huh? Remember, this group is the ooh
The oohs.
at the 1, 2, 3, 4 ooh.
Yes?
Shalala is 1, 2, 3, 4, 1. Shalalala.
Mm-hmm.
And the doo-doo will be 1,
Doo-doo.
2, 3, 4, 1.
Doo-doo.
All right,
Okay?
let's see how this goes.
All right.
We're going to go into the Guinness Book of Records.
Yes.
So all of them will be
Let's do our best, okay?
backup
Everybody.
singers.
We'll do our best.
Okay, you ready? Okay.
Only one guy is ready.
Yeah.
One more time. Are you ready? That's the energy.
Do
Okay.
your best, okay? I think someone's recording this, right?
Oh, no.
No. Okay, here we go. Group 1 first.
When the night has come and the land is dark and the moon is the only light we'll see. No, I won't be afraid. No, I won't be afraid. Just as long as you stand by me. If the sky that we look upon should tumble and fall, all the mountains should crumble to the sea.
One more time.
I won't cry. I won't cry. Oh, won't shed a tear. Just as long as you stand by me.
Everybody.
Come on, everybody sing.
Darling, stand by me. Oh, stand by me. Stand by me. Stand by me. Stand by me.
Come on, everybody clap your hands. Come on, here we go.
Stand by me. Oh, stand by me. Oh, stand by me. Stand by me. Stand by me. Whenever you're in trouble, would you stand by me? Oh, stand by me. Stand by me. Stand by me. Stand by me.
Thank you, everyone.
Well done.
For next year's gathering, we will have a choir. Thank you, everybody. Once again,
We
a
are
big round of
hiring
applause
backup singers.
for Joe, Jackie, Rita, and
Thank
myself.
you.
Thank you
Thank
very
you.
much, everybody.
Kamsia,
You've been
thank you.
fantastic. Back to your normal program.
Back to the boring bit. I'm so sorry. Thank you very much. Another round of applause for Puranak and Sayang. I got a feeling that they'll be back. Okay. It's time to move to our next segment now, and it's about redefining impact. Without further ado, a fantastic host is going to take you through this segment. Please welcome Dr. Joanne Yung.
Thank you so much, Antima. I have to say that I hope this next section actually will not be boring part. I'm looking forward to, I think, what's a really fascinating lineup. Thank you so much again to Puranak and Sayang for kicking us off after lunch. Really a great job. Thank you, Alvin and team.
Yeah.
This next panel is also a range of diverse voices that we hope will bring some harmony to, I think, what is a fascinating topic. And I think very good afternoon to all of you. I think the morning we've talked about scaling impact and a lot of things that we see in growing this ecosystem. So after lunch, we'd like to take another step back and think about redefining impact. What does impact mean to us when we conceptualize this from different perspectives? What can we learn from this? And how can we operationalize this so that it's not intangible, but actually is something that we can use as a compass to guide our decision making across various sectors? So again, I'm very happy to have a panel of diverse voices from different sectors. And without further ado, I'd like to invite our panelists to the stage. So starting here on my left, I would like to invite Yun Ching from the Agency of Integrated Care, the Chief Strategy and Research Officer. Professor Jose Maria Valderas, also known as Chema, from NUHS, the head of the Department of Family Medicine. Elil from the Sing Health Patient Advocacy Network, very important, a mentor and a voice here today for us, representing patients. Ron, the Assistant CEO of SG Enable. And last but not least, Lynette Leong from Capital Land Investment, who leads as the CEO, the ESG Fund and Stewardship area. So welcome very much to this panel. Each of you today will be sharing with us your perspective on this very interesting topic. The perspectives here will be brief. All of our panelists have been given 5 to 7 minutes to share. So just a snapshot of their view on this thing. I hope you'll see a very diverse range again of interpretations. And we'll hope that all of you also have been taking note of how you can ask questions. So please do that via the question platform for the panelists later so that we can bring up the Q&A after everyone has gone. So without further ado, I'd like to invite Yan Xing, please kick us off.
Yeah, I prepared a deck of slides, so just waiting for it to load up. Yeah, so it is quite hard to define and measure impact already, and I think it's even more so in the community today, and that's where AIC operates in today, the Agency for Integrated Care. So we outreach to seniors at their homes, we understand their needs, we refer them to services. We also have colleagues at the hospitals, working with hospital colleagues to just help seniors or clients who are discharged from the hospital to access services and schemes. And we do all this through our partners in the community, the home care providers, the nursing homes, the active aging centers to really provide the care around our seniors and clients to allow them to age in place in the community. Next slide, please. And I've just spoken about where we operate really at the individual, the community, the sector level, and we also do some roles for MOH at the national level, grants disbursement, managing things like CHI INNOVATE, mental health as well. Next slide. And all this really come together because we do have people on the ground, they understand the needs, we talk to our clients, our seniors, we touch them, we see what they want and we link them up. We then look at what the gaps are in place today, and then we work with the community, our partners, to put in place services to really address these needs. And by working with our providers as well, we also understand the capabilities and we help put in place programs and schemes to really build up the ability to deliver these services. And I think last of all, we work together with partners, the hospitals, the regional health systems, to really bring all that together in the community to really deliver those services to our clients. Yeah, so that really gives a quick overview about what AIC does today. And as you can see, a lot of the work that we do is really quite diverse across many domain areas. And because of that, there are some challenges on how we see maybe impact being delivered and also measured and defined. And in the community, I think a lot of the outcomes are really social in nature, not so much the healthcare. I mean, healthcare is still important, but a lot of things that happens in the community are really factors beyond our control. So let's talk about things like family dynamics. So we talk about healthcare, maybe they are not going to the medical appointments because they don't have people there, or the family support is not there. So when you talk about outcomes, we have to look beyond the medical factors to look at the social side as well. And because AIC's work really involves working through a lot of partners, it is quite difficult sometimes for ourselves to measure directly what our impact is. And I think in our experience as well, when we run pilots, we try to evaluate how successful they are, how impactful they are. But oftentimes, we use traditional metrics like cost effectiveness, which is quite common in, I think, the healthcare setting, things like daily, but a lot of these don't really apply in the social sector. For example, in our experience, because we provide some of the social support to seniors, many of them are isolated, they can't go for medical appointments, but once you put in place a program, healthcare becomes more accessible because there's someone to bring them to the medical appointments now, and in a way, because of that, healthcare utilization increase, cost increase. So we can't traditionally use like cost effectiveness as measures. So we do want to look at other metrics like quality of life. And when we work with partners as well, the partners, they are manpower constrained. So collecting data is one challenge. So that's something that we always have to be aware of. And I think lastly, the community, I think we tried to look around. There isn't really a strong consensus on how do you measure impact in the community care sector, because the range of services, the clients are so diverse out there. Many different social conditions, many social issues, medical conditions as well. So it's been quite challenging to have a very coherent measure. But I think despite all this, we are trying to make little inroads. So I think for ourselves as an organization, even though we say some of these are really beyond our control, we try to have outcome-based monitoring as far as possible. So if not to manage performance, but really monitor outcomes and just give ourselves an idea whether we are headed towards the right track or not. And I think within ourselves, we also try to be very diligent about just developing theory of change. So making sure we know how we operate as an organization, how the different parts of our work link up together to deliver the outcome and impact for our clients. And whenever we deliver or try to run pilot programs, we have also put in place where we try to clarify the logic model first, and then understand how the different pieces work together and putting indicators just to make sure that we are on the right track or not. And I think data collection as well, that's key, as I mentioned earlier. So when we run pilot, making sure we want to measure impact, we work with our partners to really understand and just make sure that there is some discussion about how we can collect data, but also understanding that the data that we collect eventually may also be not that clean. So we do have to spend a lot of time just trying to understand and clean it out a bit and have the discussion with our partners just to ensure that this part can be done as good as possible. And I think lastly, because we do have quite a strong machinery, our silver generation colleagues, they are on the ground, they can collect some data. So we try to also write on that to collect some indication of how we are doing on the ground today with all the various programs that we have. And also to work with the sector to put in place a set of what we call sector goals. And we use the data and then we have dashboards that we share with the partners to align and to have a shared understanding of the direction that we're headed towards. So that we can all work together as one to deliver that impact. Okay, that's all I have today, and I'm happy to maybe just have a conversation about this later on. Thank you.
Thank you very much, and it's very heartwarming to have kicked off in this way. I will say that as an economist, I would take issue with only one thing, which is that we don't actually find a lot of cost effectiveness analysis out there in the wild. So I'm very thrilled to hear this. Actually, I think it's wonderful to sort of, first of all, start the panel by understanding that when we want to think about impact, it has to be holistic, it has to be driven by the communities that we're working with, but actually that we also have to be very humble about the services that we deliver, but the impact that we influence, and at some level we're working hard to create these outcomes, but our reach over some of these is quite challenging. And I think also the point that was brought up, which is that a lot of what we think is very meaningful is actually the most challenging to measure. So we have to be, at the same time, while we're aspirational, very realistic about what we can and should measure. I'm going to turn then next to Chema. Chema, if you would share your views, please.
Thank you. So I'm going to take you now to a related issue, but that is how impact can be measured, should be measured, can be argued, as perceived by patients themselves. So the roles of outcomes as reported by patients. Okay. Yes, this is a model which is a simplification, but what model isn't? So basically, very many eons ago, I mean, when we started to have some idea of diseases, we started with the notion of infectious disease. So basically, there was one condition, one agent, one treatment. So that's a very straightforward model, no? Disease specialist, sequential model, diagnosis, treatment, follow-up. We gradually recognized that the things were not so easy with chronic conditions. So there was one condition, yes, but there were multiple agents and multiple treatments. And the notion of the multidisciplinary team started to crystallize, and the notion of a cycle model from diagnosis to treatment to monitoring. And these days we are in the multimorbidity area. The recognition that actually patients do not have just single conditions, that all of us at some point will have multiple and have multiple at different times, a combinations of chronic and acute. We have these multiple conditions, each of them with multiple agents, multiple treatments. So deciding a plan for this is not straightforward. So we need multiple disciplinary teams. We need a system model, not a single cycle one. We need plenty of trade-offs. We need to define goals, and we need to develop networks of professionals. And there is, you can see a gradient here, which is not only of complexity, but is also one in terms of patient-centeredness that is coming to the forefront. Perhaps at the beginning, with a more simple model, it was less obvious that each patient had preference and appetites and interests that you need to take into account, but increasingly with the high number of decisions, it comes to the forefront. And this is where patient-reported outcomes can help in defining value in terms of how patients see their health. Typically, they have been perceived from a very biomedical model in which you focus on clinical management. That would be the left-hand side of the slide, and with a disease focus on measurement, and you end up using patient-reported outcome measures, but of standardized way. Whereas if you start from a patient-centered care model, you're more interested in the whole person approach, in goal setting, and individualized prompts may give you what you really need. And of course, none of them takes the whole picture, so you actually need to use them in tandem. And this is information from a very recent Cochrane review that was published a few months ago, in which we reviewed what is the impact of giving clinicians information about patient-reported outcomes of their patients. Does it change anything in how patients are treated? And you can see here a cascade of effects. So it does increase communication, it supports diagnosis. It's not so clear that there is a change in treatment. It improves the control, the level of control in terms of monitoring of the patients, not a very low certainty that it does make has an impact on functioning. And surprisingly, we were able to observe an impact in quality of life. So there are some gaps in this clear cascade that need to be clarified. But this information is useful for clinicians, and we argue also for patients. And one initiative that is trying to scale this up significantly is ICHOM, the International Consortium for Health Outcomes Measurement. And the idea underlying ICHOM is that you can focus healthcare to be outcomes oriented, to define value in terms of key outcomes, and that these key outcomes can be defined for each of the relevant conditions. So here you have outcome sets for stroke, prostate cancer, lung cancer, etc. The idea is that this core set of outcomes can be used for providing care and for monitoring the value in care across the whole pathway, from primary care to specialized care to all allied health professionals. We were able to also to develop one which is the so-called overall adult health outcome set. And with an international panel of experts and following the consensus procedures of ICHOM, this is what we were proposing. So basically, we identified that there was a need to measure general health, physical health, mental health, and social health as aligned with the WHO definition. And these are the specific outcomes in terms of physical functioning, mobility, fatigue, pain, seeing, vitality, etc. And we were able to measure them just with a very restricted number of standardized measures, PROMIS 10 global scale and 2 WHO instruments. So the idea is that it is feasible to measure impact as reported by patients themselves. There is evidence that it does provide meaningful and useful information for clinicians and for patients, which we believe is the route by which quality of life was improved in the Cochrane review. And we are making very decisive steps towards making this promise of a patient-reported outcome measurement and embedding it as a measure of value in clinical settings. And just watch this space because things are really moving forward. Thank you.
Thank you so much, Shema. So I think from Yunxin, we had heard how at the system level we need to measure change in this more holistic way. I think Shema has made a really sort of compelling statement for why actually when we redefine impact, not just looking at multiple domains, but really taking it from a different perspective can make so much difference. And having these tools and putting them to practice not only enables standardized research, it enables organizations like AIC to do a better job of measurement, but most of all, I was struck by the fact that it changes the nature of the interaction on the ground between the patient and the provider, and it changes outcomes for the patients as well. So measurement is not just a lens, but it is actively mediating that process. And with that, I'd like to turn actually to Elil, who is from the Sing Health Patient Advocacy Network, to give us a little bit more of a deep dive into that perspective.
Hi, good afternoon, everyone. So here I am, the layman, the patient. One of the reasons many of you have jobs, because without the patient, we don't need doctors or nurses or hospitals, right? So now okay, thank you. So my expertise is my lived experience. As a patient, a double cancer survivor, I was diagnosed with 2 primary cancers 11 years ago, and also as a caregiver to my late parents, right? Between the 3 of us, I think we have navigated the healthcare system of all 3 clusters on almost every institution, right? So healthcare innovation can be something as simple as filling out a form to shorten the discharge process, or something as complex as immunotherapy to target specific cancer cells, right? Any development that leads to an improvement in outcome for the patient is healthcare innovation, right? But this needs to be measurable. And how do we measure this? right? KMA has actually given some examples of how patient-reported outcomes can be measured. But as a layperson, it has to filter down to everyone who is receiving care from the institution. And not only the patient, but also the family members, the caregivers. So unless the innovation translates to a better experience, a better patient experience, a better human experience for patient, for caregiver, for family members, then it is not impactful in the eyes of a patient. Right? You can check a lot of boxes in savings in cost and leading edge technology, but that means nothing if the patient cannot have a better experience because of that innovation. So when it comes to outcome measurement, it is important that these are patient-reported outcomes, because only patients are experts in their own disease condition. They know the disease best, they know themselves best, they know what matters to them. So outcomes must be measured in those terms, right? So if there's going to be any framework to measure the impact of innovation, then this would be the outcome measurement by patient-reported outcomes. So that has to be built in. So patients need to get involved in this system of impact measurement for innovations from the very beginning. So the challenge is, where do you get these patients and caregivers who will come forward and be involved in this process? One of the places to start would be your peer support groups in the various hospitals for specific conditions. There are passionate individuals who come forward and lend their lived experience expertise. Another source will be patient organizations in our society. There are many for different disease conditions. One of them is the Ostomy Association of Singapore, of which I'm a president. We have people who are trained to sit down at a table and to talk to healthcare teams to see how we can find out what matters to the patient, right? And of course, there are PFACs. Now, PFACs are Patient and Family Advisory Councils, and the SingHealth Patient Advocacy Network, or SPAN, is one such council. Now, it is made up of, by the way, I'm a member of SPAN. I have been for the last 4 years, and now I serve in my capacity as mentor. What we have is a group of very dedicated and passionate individuals who are vested in improving the healthcare landscape for not only patients, but actually also for healthcare professionals, right? There are about 50 of us now, and we come from very diverse backgrounds, different age groups, different disease conditions. But one thing we have in common is wanting to work with the healthcare teams to see how we can improve systems, processes, and such to improve outcomes for patients and give everybody a better user experience, all right? So SPAN members are actually trained not only in basic communications. We have something called the Patient Advocate Communication Training, or PACT. This equips the members with the necessary skills to be able to sit at the table and contribute constructively to the discussion with the healthcare teams and not only focus on their own pain points. In addition to that, we also have development pathways for all the members. They are trained in methodologies like design thinking, quantitative and qualitative analysis, and quality improvement. Right, all these will make sure that they have what it takes to be a useful member of that team that is aiming to improve a process, all right? And right now, some of the projects that we have worked on include something like, in fact, one of the most important projects we worked on is the plain English glossary, where we advocate to nurses and doctors to use simple language when communicating the condition to the patient and the caregiver, instead of using medical jargon, right? Actually, I have a lot more to say, but I've just been told I have a minute left. So I want to conclude by saying that we are ACE, the Agency for Care Effectiveness. has now got the consumer education engagement arm, and SPAN is actually one of the members. We contribute to their efforts to make what they do more friendly, user-friendly, so they run it by us before they actually publish it in the media, right? And I would like to conclude by saying that SPAN is not close to one cluster. We have members from all the different healthcare clusters, and if there's any interest in working with us or to join us, please get in touch. Thank you very much.
Right. Thank you so much, Daniel, for giving us, I think, that deep dive and reminding us why we need to be here, speaking of how, at the end of the day, the user experience is actually so much wider than what we see from the clinical perspective. I myself am a survivor of having 2 clinician parents, and I will say that it can be very challenging sometimes to communicate across some of those pieces. So even if we have impact, but we're not able to communicate it or speak about it in a common language that makes sense, it's going to be very challenging for people to understand and to turn good intentions into actually a good experience for the people who should be at the heart of what we're trying to do. So I think having gone down to that level, I think we'd like to come back up a little bit and maybe turn this over to Ron from SG Enable to give us that perspective.
Yeah, good afternoon, everyone. So I'm Ron from SG Enable. So today I'm like the social sector side in a healthcare seminar. So I thought I would give a brief overview of what SG Enable is, if you guys might not know. So SG Enable is, we position ourselves as a focal agency and first stop for disability and inclusion in Singapore. So from our mission statement, it can be clearly seen that we are here to serve persons with disabilities and their families. So SG Enable creates equitable opportunities for persons with disabilities to aspire and fulfill their potential through thought leadership, sustainable social innovation, and impactful partnerships. So just to give a brief overview is that we do many things for the disability community, but we really, going back to fundamental, we see ourselves as a first stop for disability and inclusion. So we have 6 broad areas of work designed around the client centricity. So first is about providing information on disability support, training and consultancy, community integration, hiring and employment, assistive technology and accessibility, as well as social innovation, and that's why we're here today. So maybe I could zoom in a bit more on our social innovation work. So in our area of work is that we really want to seek to bring people, talents, and resources together to try out new ideas to address the complex disability challenges faced by the person with disabilities, as well as now really to look into the caregivers area to really provide them with better support in their caregiver journey, because we realize that it's not just about serving persons with disabilities, but also serving their touch points to provide the ecosystem of support. So with strong support from Tote Board, we actually have this Enabling Lives Initiative grant that seeks to bring together the best ideas from a community of non-profit organizations, social enterprises, and innovators to really create scalable and innovative solutions for persons with disabilities. So our grant is actually designed around this collective impact framework. What we try to do is really to make it as simple to understand as possible, such that when we work with different partners, everybody is very much aligned. So what we have is 5 principles. The first is about common desired outcomes. So what we want is that anyone who comes to us have a aligned and common understanding of the complex challenges or the problem statements that the sector is looking into, such that from the common understanding, all the ideas, the brainstorming of ideas, the solutions that we're looking for are very much aligned and create the opportunity for partnerships. So it's not just about people working on the individual problems that they see themselves with. Next is about common impact measurement. I'm sure everyone, when we talk about impact measurement, is about collecting data, the challenges of collecting data. So what we actually seek to do in this ELI grant is really to have a consistent way of collecting data as well as measuring the data. How do we calculate results, especially when we have so many different types of projects and different grantees that we work with. So actually we came up together with SMU, Land Center for Social Innovation. We came up with a measurement framework that actually we are able to commonalize the way that we collect the data for measurements. Next, we have the mutually reinforcing activities. So what we try to do in the grant is not just about being grant administrator, processing applications, right? But we actually create opportunities for partners and grantees and the social service agencies to come together to share their ideas, to share the problems they are facing on the ground, and really to come together to think about what are the solutioning, what is the journey that we want to go through together. So we actually create networking sessions for the grant workshops as well. Fourth, we have the shared learnings. So of course, it's not just about developing solutions. We hope that through the journey of developing the projects, the grantees can also share their learnings to the other social service agencies, right, to really build up the sector capability. And lastly, like I said, SGE, we don't see ourselves just as a grant administrator, but really as an enabler, right? Together with Tote Board, we want to drive and guide the solutioning for the disability sector through by creating different platforms, different opportunities for people to come together so that we can have a collective impact. So what we've designed here in the framework is really something simple to understand, such that whenever people apply for grants, it's very clear what SG Enable and Tote Board is looking for. So I hope that this gives you a good context, although brief, on the work that we try to do, as well as how we try to guide the sector development as well.
Thank you so much, Ron. And I think what I was really struck by actually is how actually collaborative this process is that you're speaking about, that you really want to say, we're addressing such a broad section of society. We want to be person-centric in so many different areas, but what we need to do is bring everyone together, from the measurement to the outcomes to actually this process of getting support and deciding what we're going to do, just so that we can all move forward as a sector. So I think, having done that, I'm going to close off the panel. Lynette, thank you for breaking the Manel situation. I'm very happy, although it put us as far away from each other as possible, to break, I think, the solidarity. But thank you so much for being here. I think we've discussed actually in great detail, I think, various levels here. The level of the healthcare system, the level of going down to looking at operationalizing provider and patient interactions, to the patient level, the sector level. And what I think we want to hear from you about is really at the highest level when we're thinking about these new macro outcomes, not just the populations we are serving today, but the future populations. What does it mean to think about impact beyond even just these groups, but the bigger sustainability questions that we are asking actually in many, many sectors outside healthcare and even social care today. So Lynette from Capital Land Investment.
Thank you, Joanne, and good afternoon to everyone. I don't want to say that it is from the highest level, because I think in sustainability, you have to start from the lowest level. I just want to have a show of hands. How many of you know Capital Land? Just to be sure. Okay, all right. Okay, good. All right. I hope you either have shopped at our malls, or you're living in one of our condos, or you're working in, probably not in our office, but maybe you're our tenant. All right. So actually, I'm the most unmedical person here, I guess. And so the medical glossary is absolutely important to me. So from the medical perspective, I think, yes, I am a patient, a visitor, and caregiver, hopefully not frequently. We are also a landlord of clinics, probably not hospitals, but clinics. So I'm coming from, I would say, is more from our real estate perspective. So I hope that there will be some gaps. So maybe Joanne can help me to fill in those gaps, all right? Okay, so how we look at impact is, first of all, who are we impacting? Oh, no. So in our, oh, sorry, that's, okay, thank you. Okay, so from our perspective, these are the four groups of people groups that we are impacting. I think when we look at impact, we have to define who first. And so our employees, of course, very important. Our investors, because we're a public listed company, and because you need money to fund a lot of things, right? So investors are important. Every quarter, they will chase us for our results, our financial results. Our customers, so they consist of tenants, those who pay rent to us. They are also our shoppers, those who come to our malls to shop and to patronize our tenants. They could be homeowners, they could be lodging. That means lodging, we have lodging as in our hospitality group. We also have office tenants. So these are all our customers. And what we do will impact them. And then the last but not the least is the community, which is the community at large. It could be the government, it could be our suppliers, those who come to provide services to us. And these are all very important people. So we start from there. And when we look at sustainability, it is not only about investors alone. You know, traditionally, we think of companies as just making profit and maximizing profit. It is still important, but we need to look at many other aspects. That means we have to look at the environment, we have to look at the social aspect. So how we look at sustainability is a very, very big topic, right? So I needed to distill down to areas that are related to what we do as a business. So in healthcare, I guess you also need to look at different pillars. But this is a good guidance, I think, that may be applicable to healthcare as well. But this is relevant to us. So in sustainability, very broadly, you can actually break it down into ESG, which is environment, social, governance. All right, so in environment, in our industry, we look at it from the building perspective. So that's why we call it build. And what we want to do is we want to build resilience in the resources that we use to build our buildings and to operate our buildings. So for example, like the air conditioning, the energy, right? You need energy to operate the building. So how can we make it as efficient as possible? How can we conserve the resources? Water, for example. And I think these are all very relevant to the healthcare sector. So from the social perspective, what we want to do is to enable thriving and future adaptive communities. Those people whom I showed, the 4 groups of stakeholders, we want them to be thriving, right? Whether they be our tenant, our employees, or people who visit our buildings, we want to always be them to be thriving. We want them to be future adaptive, right? There's a lot of uncertainty in the future, but whatever we plan, we will plan for the future. Then at the same time, because it's a very competitive landscape out there, we also want to establish leadership in what we do. We want to be ahead of the curve. And therefore, we look at areas like innovation and finance and so forth. I'll come to that later on. And all these have to be anchored by strong governance, which is the G. All right, and in summation, we have to deliver sustainable financial performance because we are a public listed company. So I wanted to, oops, I thought I had, okay, never mind. So I mentioned about social. I think social may be more relevant to healthcare, but I think build environment too, because whether you're occupying a building, a hospital, the things that you use, for example, my very, very layman understanding, like your masks, your needles, and all that, how do you dispose that in the most sustainable way so that you don't pollute the environment? So all these are issues, a value chain of things that you need to think about. And then from the social aspect, for us, we are looking at occupational health and safety. So people who occupy our buildings, we must ensure that they are safe, they are well protected, they have good indoor air quality. And then people who are constructing our buildings, they need to be safe as well. So one of the targets, we talked about measuring, setting targets. So one of the targets that we have is 0 fatality for our people, 0 death, you know. So I think that it's necessary for us. And also, number of injuries have to be reduced. So we set certain numerical targets for each of these. And then in accelerating, we set innovation and collaboration, which brings in the technology part. I wanted to just quickly give a case study. I hope you have shopped at Funan. It could be more familiar with you. So we have many case studies, so I thought that this one might be useful to help you to understand what it means. So when we say the building part, the build, so we say energy efficiency is important, how we power all the lighting or the lifts and everything that is inside the building. And also, we want to provide renewable energy, especially right now where energy prices are escalating. Yeah, we need to think about renewable energy sources. There's abundance of sun, wind, and the water, right? So how can we use that to the maximum? And so we want to provide the social aspect, as in how do we make the environment very pleasant for our shoppers and our tenants. So we have things like the rock climbing wall, and then we have a cycling path, to promote health. And then we also have this outdoor garden on the top floor. If you have not visited it, actually, there's a restaurant there, so it's farm to table. You grow, and then you can actually eat it. And if you have your garden within your building, you don't need additional transportation from your suppliers, and then that will reduce the carbon footprint, right? So these are the things that we need to start to think about when we design a building. And then also various types of digital initiatives. Now, one of the things that are also challenging us is about e-commerce, online shopping, right? So we hope that people still visit our malls, but in order to cater for those who don't, we also use digital online shopping to gather all our tenants to be on a certain platform called Capital Star, so that people can also shop online. So just like in healthcare, I guess you also have the digital healthcare as well. So innovation is important to us. And how we strengthen our innovation is we have 2 areas right now, which is the Sustainability Challenge, which we conduct on an annual basis. I think you also have the Chisel. Great effort. So what we do is we actually source globally for solutions. There are many solutions out there in the world, and I see that on the second floor you have very promising ones as well. So we actually gather them and we provide sandboxes. That means at our properties we can use our different properties to pilot the solutions and then to apply and scale them up across the world. And then the second thing that we have is a smart lab, where we bring in different parties that have got solutions already, come together, collaborate, and then maybe co-create something new or even not new, but then that they can link all the solutions together to form something that is easy to understand and impactful. Then at the same time, from the healthcare related perspective, we are collaborating with the Queenstown Health District to look at how we can tackle the aging population, the challenge of aging population. And I'm actually part of that. So what we do is we are funding it partially, not completely, and then we are also testing different types of technologies to see how we are able to help to address this challenge. At the same time, we also have productivity. I need to be productive and finish my presentation in the next minute. So there are areas of other technologies that we use to see how to improve productivity in healthcare, as well as indoor air quality and sustainability. So thank you so much.
Thank you very much, Lynette. Right, I think this is a new frontier a little bit for us in healthcare, both from 2 directions. One is that we used to talk about patient health, and we talked about public health, and now we talk about planetary health. I don't know how many of you have sort of been engaged in these new discussions where we become aware that actually the climate and health of the planet is very deeply integrated with what we are doing and what we affect. But I think also what you've actually outlined for us with this presentation are some of the questions that we are asking ourselves about how, as a sector, we are going forward. How do we invest in assets that actually are sustainable and green on one level? How do we organize governance to ensure that we galvanize this? And events like this are great for that. And also, I think the social impact and how we organize as a sector. We as healthcare are a huge sector. We employ people at very large levels. And actually, we know that the way that we take care of our own workforce, the way that we take care of the mental health and well-being of all of the people who are here today is a huge part of our social impact as well. And so we are not separate from society, but also part of society. So I think the things that we've seen here, both in terms of direct input into how we are building assets for the healthcare sector, but also as a view to how we can keep asking ourselves these questions about how we conduct ourselves is actually really, really exciting. So I would like to encourage everyone, if you have not yet asked a question, to put the questions on the Slido platform for the Q&A. And we're going to go back, I think, to the Q&A, starting actually from Yunxing. So Yunxing, we are back again to you. And one of the questions that has come to us from the floor is that you mentioned QOL as an impact measure and the use of qualitative measures as well, which is actually really helpful to build up a more sort of holistic picture. But QOL is a major effort. Collecting QOL data takes time. It's not always possible to do in the short term, and it's not always appropriate, actually, because often it takes time for these things to happen. So how does AIC go around building interim or milestone data into the evaluation? If you can't get to QOL right away, what do you do, or how do you advise projects to build in some of the interim steps so that we can still track our progress to impact?
Yeah, so I guess when we roll out our programs, we talk to our partners to maybe just understand what's realistic, what kind of measures can we collect. So I mean, there'll be the inherent, the output measures, the process indicators that we try to make sure that the things are on track. And then what we try to do then is things like outcome measures like surveys. We will just maybe ask the clients how they are doing. And it's simple survey. So we keep it rather simple to see whether they have benefited from the service, they like the service, whether they're satisfied with the service. So maybe not a full QOL framework, but we do try to maybe just insert some questions. The other thing that we do is we try to write on the existing surveys that we do already. So we do like client satisfaction surveys for things like home care services, center, nursing homes. So where possible, we try to look at the results that we gather from these surveys and see whether some of these other interventions that we put in place, it does make a difference or not. As I mentioned, the other thing that we do also, because our Silver Generation Division colleagues do go out to talk to seniors, they go knock on the doors, they spend, I think, 30 minutes to up to 1 hour even, to just talk to seniors right now to understand what their needs are. So it's a new kind of approach that we're doing called preventive health visits. So it's more about sitting down. It's kind of like, maybe I wouldn't say health coaching, but it's just really understanding, having that conversation. This is a shift from what I think our Silver Generation Division colleagues used to do in terms of communicating. So through that whole PHV type of approach, we are also able to maybe just collect some information and data, and then we try to maybe, where possible, try to track back to whether they are participating already in some of our programs, and then we will see whether some of these programs that we put in place does actually benefit the clients or not. So multifaceted. So we try to see what's available out there to use as interim measures.
Right. So it's very practical at the end of the day, right? We have very lofty goals, but actually on the ground, they are very pragmatic measures. And we can leverage things that we're already doing, and we can take very concrete steps to make sure that that patient level interaction is captured. And most importantly, as you said, that it is fed back and acted on the ground. And I think that's really very key. Gemma, I'm going to turn to you. We have a couple of technical questions about measurement that I'm going to fuse into one. I think people are very, very fascinated by the instrument that you've shown. On the ground here, I think we try to measure, patient-reported outcomes, but we also have a number of quality of life instruments that are on the ground and candidates for use. For example, we have the WHO BREF or WHO QL instrument on the ground. So I think the general question here would be, looking at all of these different instruments that we could use, what is your opinion about the best type of approach to take with community-based settings where you want to measure constructs like quality of life? Is the instrument that we spoke about still relevant, or what about approaches such as the WHO BREF?
Thanks. There is really, it's one of the main problems of PROMS is actually that there is so much to choose from. And it's not so easy to find the way through all this forest of instruments. The ones that you're proposing are reasonable, and by and large, many others would be too. I think that what is key is that we are some technical developments are facilitating developing crosswalks between all these instruments, so that it is safe to use the shorter ones, the ones that are for which patients seem more familiar with, that elicit responses that are include questions that are more typical of their own environment. And in terms of optimizing the metrics, we can do that afterwards with support of the mapping and support of the bridging to the other instruments. I think that we are at a juncture in which we're using approaches that we will not be using the next 5 or 10 years. So the current instruments are, I would argue, provisional. It's very likely that in very few years' time, we will be using computerized adaptive testing, whereby, based on the responses of the individual, the best items are selected, and just with a handful benefiting from very large item banks, which will be hosted in servers, you can get very reliable estimates with just a handful of items coming from very different instruments. The processes are being developed. Some of these examples are already available, but they are perhaps not fit for purpose for everyday practice. So in the meantime, it's safe to continue using those that are being proposed. But I'm really hoping that very soon we will be a steep change in our capabilities in measurement.
Okay, super. So I'm hearing actually that we're also looking at technology and innovation in measurement itself, which is going to enable us to do this more efficiently, have a better experience for the person taking the surveys, because guys, everyone hates surveys. This is just humanity, right? I mean, right. So a better experience for those and actually a better outcome. And when we're more agile, we're going to be able to respond better. So technology is key, but also what guides us on the ground is that it provides a better context and is more reflective of the conditions in which we're doing these measures. And so I'm going to move that conversation actually over to the other bench to actually talk again about how we activate changes on the ground. And I think one of the questions that we have here actually for Elil is that, while we're talking about all of this technology, at the end of the day, having the patient be part of that process of designing the questions that we ask is so important. And you've spoken a lot about equipping patients to be in that position and advocates. But we do know that healthcare providers sometimes are still very wary of that as a process. And we're still thinking about how to do that on the ground. So what's the best way for us to start on this journey? And you've already begun talking about this. So I want to give you the extra time.
Thank you. I needed that. Yeah. So one of the things I wanted to say earlier during my sharing was that we have actually come up with a patient engagement toolkit that we can offer to healthcare workers to tell them how they can engage us in this advocacy group, right? And I think it's only natural for the healthcare providers to be wary. This is not something that has been around for very long in our part of the world, right? It's still very new. And I think that a lot of it has got to do with building trust for the healthcare providers to trust that the patients have a vested interest also to improve outcomes for, across the board. Not only focusing on patients' pain points and telling the healthcare providers, you should do this, and this. No, it's to come to the table and discuss what is best for the patient. And at the same time, something that we are also passionate about is how we can improve outcomes for the staff, how we can make it a better staff experience. So once I think we've had enough conversations together and the trust is built, and I think we can then make quantum leaps to improve the experience for everybody in healthcare.
Great. And I really like that reflection that it is a trust building experience, and that repeated interaction and sort of just building that understanding that actually we are advocating for ourselves, but actually for the whole system and everyone in it. I think that's an important recognition. I'm going to actually extend that question actually to Ron. One of the, I think, questions from the floor is that, which is related to what I think Elil has been talking about, is that this process, I think we say a lot about being participatory and we say a lot about bringing everyone to the table. But when they get to the table, it's very hard to manage when you have so many different people, all of whom have a say in what goes on. So you, I think, really very eloquently described how every part of the mechanism of SG Enable is built towards this collective impact. But how do you actually manage that? And how do you decide when you have so many different voices, how to determine an overall direction, what stays, what goes, how to pilot that ship?
I guess the very first, most critical part is to bring in the community we are serving. That means for my area, it's really about persons with disabilities as well as the caregivers. So I think this is a part where we actually, in SG Enable, where we have all the different teams working with the community. So in SG Enable, we do very regular check-ins every 3 months, right, to check in actually what are all the ground feedback from our community to really see what are the challenges, what's the feedback on the programs from the community itself. And so that in SGE, we can actually, within ourselves, really try to distill what are the problems areas, the problem statements we should be looking at. But then what we also have in SG Enable is what we call the disability professional networks, where we have more than 80 social service agencies that we partner with, where we also hold very regular sections to really find out what's the ground feedback and what are the challenges that agencies are facing. But what we are trying to do very much differently is to get everyone to share their ideas, because I think most of the time when you have sharing sessions, it's always talking about, oh, these are problems that we have, that we are facing on the ground. But I would say that, to be very frank, the challenge is about getting people to share their ideas. What are the areas they are looking into, what they are passionate about, what they want to work in for the next year or so. And really from there, create the opportunities for partnership. Because I must admit, in the social sector, we have quite a lot of overlaps in efforts as well. So in SG Enable, as an enabler role, we are trying to synergize the work really to bring together for collective impact. So what we're trying to do is really to get people to share their ideas, to really exchange ideas and build on each other strengths, and also what are the challenges we are facing.
Great, thank you so much. And I think that actually really also very eloquently speaks to one of the issues that we have sometimes, because we are so passionate. When we have sharing sessions, they turn into complaint sessions. And then we sort of come together and then we sort of feel a little bit better because there's some therapy going on, but it's hard to motivate. It's hard to motivate. And actually, you know, again, managing and facilitating that conversation as a coordinator is so important. Lynette, we have so many questions for you. So many questions for you. But I want to maybe pick up on that thread and transition that to one of the, I think, most important questions that we saw here is actually coming from a situation where you have to galvanize people to be excited about sustainability, some of these very abstract concepts, right? Sometimes we say it's difficult because we want people to care about others. That's very difficult. We want people to care about the future. That's very difficult. And then when we talk about things like this, sustainability, we care about other people in the future, which is twice as difficult. So how does CapitaLand, you know, in your experience, nudge people or the employees or their stakeholders towards this vision, to take action and to buy into this?
It's good to hear that there are a lot of questions. That means you're taking an interest in this topic, or you're taking an interest in the shopping. No, so I thought the question is quite interesting. You said nudge, right? Nudge is, so I'm wearing an Apple Watch, and it nudges me to breathe, and nudges me to stand so I think technology is very helpful for that. And we do use technology in many ways. But let me start with a very more traditional approach first. So we use a top-down and bottom-up approach. Top-down, which actually usually works, and it is really about setting KPIs. Measurable impact, right? So, and our KPIs are actually tied to the compensation of the CEOs. So that always works. But then it has to filter down through the cascade down into the employee. So how do you get them to behave as such, right? So I think it is the bottom up that is important, which is how do we educate? First of all, create the awareness, because sustainability is still a pretty broad topic. So we have to narrow it down to bite-sized pieces that they understand, that they can relate to, and they see that they can make an impact, they can make a difference. So that will be important. So that engagement part is very important. So Apple Watch or technology. So I mentioned about occupational health and safety, which is one of our targets. 0 fatality, right? And then reduce number of injuries in our properties, whether they be at the construction site or at any of our properties that are already in operation. So how do we do that? So using technologies, one of the ways is we give this. We all use a mobile phone. So wherever we go, we see anything that is not right. Like say we have a puddle of water there on the floor, and potentially somebody could slip and fall, right? So we should be taking responsibility and snap the photo wherever you are. Not to incriminate your colleagues, but then to actually snap it, and then so that it can be directly sent, that will be sent to the relevant department, the building operations, and they can be more aware. Then they can send the people down straight away. And then whoever they send down, also they are timed, the reaction, the response time, they are timed. So when they see, they got to quickly go down and do something about it, and that's clocked in. And then that is then goes up to the value chain again, back to your targets, and so that you're productive, you are addressing an issue immediately, especially where it is urgent. And the report is self-generated also, it goes back. So you also cut down on manual work, right? Having to report. So one of the things that we always find the staff being they're supposed to take action, but not to sit at the office to churn out reports. You take too much time churning out reports. So what is the best way to cut down on the time? And that is to have technology, right? If everything is input, they just key in the bare minimum using your two thumbs, and then everything all is generated into a report, sends it up straight away, then you cut down a lot of time. And people will be more willing to want to do something when they don't have to churn out reports. So I think this is one of the ways that we nudge people. Then, of course, the other thing is that we make things fun. I think we need to get some ideas from your team earlier on, the music part. I think that's really fun. To just get people excited about wanting to do well for the environment.
Great. I would actually also love to see that team back again as well. Okay, I'm going to actually wrap the panel up because we are rapidly running out of time, shockingly. But I'm going to tell the panelists actually, I'm going to ask you guys to please think about just one word or phrase. What do you think is your top priority? Your top priority for achieving this new redefinition of impact? What is your top priority, just in a couple of words? And while the panel is thinking about it, I'm just going to, I think, just sum up a little bit of what we've heard here. For me, this has been really sort of a great panel just to reflect on how we're seeing these impact conversations at every level of the healthcare system. We're seeing it at the macro level, of what healthcare as a sector should be doing to think about itself as an employer, as a producer, as an integral part of the economy. We're seeing it at the meso level, where we're thinking about actually what do funders, what do coordinating bodies, and what do actually agencies like AIC do at the service delivery level to promote those conversations and measures and actually act upon this broader definition of impact. And we're definitely seeing it at the micro level, where we're asking how do we better understand the patient or the person perspective, and how do we actually make sure that it translates into the actual experience, which is why we are all here in the first place. So with that, I'm actually going to turn the last word actually back to our panelists, and I'm going to actually start in a more exciting way. So I'm going to actually begin with Elil, where the patient journey starts. What is your number one priority, would you say, or your big wish for redefining impact?
I would say inclusivity, because more often than not, innovations are targeted at people who are, I won't say targeted, but they benefit people who are tech savvy, who are educated, who are English speaking. So there are large groups out there who are not so tech savvy, who are not English speaking, especially the elderly who don't have anyone to help with. So I think any innovation to have impact must make sure that every group is taken care of.
Perfect. Yeah. So we've heard so much about innovation, but let's make sure it covers the invisible communities and doesn't create more inequity. That's a great segue over to Ron. Ron.
Yeah, I think something similar. I'm an engineer by training, so I'm very focused on data as well. So it's really about data collection from the unconverted because I think in the sector itself, we believe there's a lot of persons with disabilities or families with persons with disabilities that are out there that we're not reaching out to. So how can we best reach out to them and collect the data to understand what are the challenges they are facing, what are the support or the system that's required to support them. So I think what's keeping me awake is reaching out to the unconverted.
Great. And I think that's also very much, again, in line with the fact that we are all preaching to the converted very often. And so we feel great after we've had these conversations, but actually for them to have meaning, the conversations have to be difficult. If they're not challenging, then we're not talking to enough people. Maybe I'll go to Lynette.
I will bring another I. Besides inclusivity and innovation, that's intentional. I think we need to be intentional in what we want to, if we want to derive impact, then it is about setting targets to be intentional about it and then having a pathway to getting there. So no use just talk, and then it filters out and then no impact is achieved. So intentionality.
Oh, I love that. And as an evaluator, I think that's really true. We often talk about when we talk about impacts, being a data-driven culture. And I would argue that we have a lot of data. We actually don't have a lot of insight. Right? The problem is that we collect data almost ad hoc, like toilet paper shoppers before a COVID pandemic. It's there. I should get it. I will need it. It doesn't matter. And so when we have piles and piles of it very often, but we don't distill it into the things that we actually need to make it go forward. And in order to do that, we need the intentionality. We need to be able to draw on the best possible evidence. And then we need to make actually strategic plans for how we go forward, actually collecting that data, doing it in a feasible and reasonable way, and then again, feeding that back. And without intention, we're just sitting on a pile of confusion, really. Maybe I'll turn that back to Chema, because you did mention, I thought what was very close to my heart, the fact that we are in a sea of options when it comes to measures sometimes. It's not that we are lacking of choices. It's just that being systematic, intentional, and actually driven with outcomes to make those choices. What is your wish list or your house on fire for redefining impact?
I think that the critical thing in relation to this is changing the default approach. So by default collecting prompts. So trying to, having to argue why in any interaction with a patient, with an individual, why wouldn't there be a value in using information about how they perceive their symptoms, how they perceive their functioning, how they perceive the quality of life. And the notion that it's nice information to have, but not sure what to do with it, will change dramatically. I think that the clinical trials demonstrate that when the information is provided, clinicians start to know what to do with it. But it's most of the time because it's not part of the landscape. It's just like an afterthought. I think we need to change the default assumption. So it's not, let's try to use it as much as possible, but rather, why are we not using it in every single occasion?
Fantastic. I feel compelled to put an I on it as well. So I'm going to call this inertia. So we want to move away from the inertia of doing things the way that we've always done it. And instead of saying, why should we not have why should we have patient outcomes, to really say, why do we not have patient outcomes, and change the frame from opt-in to opt-out. Okay, I'm going to actually end here where I began with Yinxin for the last word. What is your top priority in this area for redefining impact?
I guess for me, I'd like to maybe offer another I. So it's integrated, not because it's in AIC, but really integrated. Just having this shared agreement on what is the impact that we all want to measure. I think with that, we can maybe streamline, simplify data collection, because we don't have to collect different data for different things that we're doing. So it would make, I think, things a lot easier. Yeah.
Perfect. And that was, 5 eyes on the problem, which I think is terrific. Thank you all so much for a great panel. I really appreciate that so much. Guys, please, a round of applause. That was wonderful. And to our panelists, thank you again for being here with me. Please take your seats. And we're going to move on to the second part of our segment here today. So coming up next, we have with us, thanks again to technology and innovation, Samir Gray. So Murgray is actually the director of the Oxford Value and Stewardship Program, and he's going to be bringing us his presentation today on the same topic of redefining impact, but from the UK. Hello, Mur, are you with us?
Hello, can you hear me?
Hi, yes, thank you so much for joining us so early in the morning from the UK. We are very excited for this presentation. So over to you.
Thank you. Well, I'm going to tell you about the future. Not because I get visions. Visions get you psychiatric referral, but because the future is here. It's just not evenly distributed. And I'm going to share my screen now, thanks to the wonders of Zoom. The future is not like the South Pole, a destination waiting our arrival. The future is much more like the Suez Canal, something we have to imagine, design, plan, and build. You see, the challenge ahead looks like this in every country. Need and demand are increasing faster than resources. And by resources, I don't only mean money. The more important resources are staff time and carbon. These are the constraints. And we now know that more of the same is not enough, and we need a revolution. Are you still hearing me all right? Can you still hear me?
Yes, yes, we're doing well, thank you.
Good.
Hear you? Yes, we can hear you, Emil.
Yeah, fine. So, why is our need and demand increasing? There are 4 causes which I've listed here, and I'll just briefly describe them, and they'll be the same, I know, in Singapore. Firstly, population aging. And everybody blames population aging. The other half of my life is a program called Living Longer Better. And many of the things that we see as people live longer are not due to aging. We can reduce the risk of dementia and frailty. But this blue sector in the Venn diagram shows that it's other factors that clinicians determine that are the main causes of need and demand. The first of these is the development of new conditions. And here's a condition called MGUS, monogammaglobulinemia of uncertain significance. Uncertain significance. Yet look what the Mayo Clinic is offering to people who've got a positive blood test. I nearly had this diagnosed myself until I told them not to take a blood test or to restrict the number of chemicals they were measuring in my blood. So, new diseases. Changing the threshold for type 2 diabetes. This increases need and demand. Then there are new interventions. And I set up the screening programs in the UK, and we decided there was not evidence to screen for glaucoma. But every optometrist has now bought one of these little machines, and referrals to ophthalmology are increasing at a dramatic rate because of new technology. And I'm a great fan of new technology. I've got a stent myself. So new technology is wonderful, but we have to keep a tight grip on it. And then there's this fascinating one called by David Eddy, the increase in the volume and intensity of clinical practice. And here's what's happened to laboratory tests in England, and the trend has gone on. And this is not because GPs are asking for more tests, but because laboratories are offering more tests, or shall I say, the machines in the laboratory are offering more tests. And it means now that a doctor might spend an hour a day looking at lab results that they weren't even requesting at this turn of the century. So, those are the 4 factors. Population aging, not very important. Diseases of unknown significance, new conditions. COVID obviously was a factor, but many other new conditions are of uncertain significance. new technology, and then this fascinating one of the increasing volume and intensity of clinical practice. More and more imaging tests and treatments. And at the same time in England, we are offering fewer people smoking cessation. So, what are we going to do? Well, we've done a lot of good things in the last 50 years. Prevention, the use of evidence to ensure we're providing only cost-effective interventions, and improving outcome by improving quality and safety and reducing costs. All wonderful, but they haven't closed the gap between need and demand because they don't tackle these four factors I've been talking about. And there are still three huge problems that are left. The first of these is unwanted variation. And Jack Venberg described this first in the Dartmouth Atlas of Healthcare. And that's variation that cannot be explained by variation in need or patient preferences. So here's a map of knee ligament reconstruction in England. Look at the variation. There's no way that can be explained by variation in need. Here's variation in hip replacement in England, using the population as the denominator. The population as the denominator. So is the high rate right, or is it overuse? And is the low rate right, or is it underuse? Now, overuse is the key issue, and this is the famous drawing by Avedis Donabedian. As you put more money into a health service, the benefits go up, but then they flatten off. The law of diminishing returns. Unfortunately, in healthcare, the more healthcare we do, the more harm we do. Now, high quality healthcare does a little bit less harm and a little bit more benefit, but it's still an inevitable consequence of giving people pills, operations, radiation. And what Donabedian did was to subtract harm from benefit. And if I were speaking in a public meeting in Singapore or in Oxfordshire or Italy or wherever, I'd be asking people, not only the clinicians, but in a public meeting, where have we gone beyond the point of optimality? And I'd like you all to think about that at the moment. What usually comes up would be imaging, lab testing, prescribing, admission to hospital in the last year of life, and even elective surgery. We've gone beyond the point of optimality, and we're wasting resources. And waste is using resources for one thing that would give you more value if you use it for another thing for the same group of patients, or it was used for another group in the population. And then the second problem that's persisting is inequity and underuse. And here you can see in a study in England that poor people get less hip and knee replacement than people from the least deprived groups in society. This is NHS. There's also the private sector on top of this. So underuse and inequity. So, what are we going to do? Well, the new paradigm, which incorporates the previous paradigms, is called value-based healthcare. And this is the European Union definition of value, which we were closely involved in before we sadly left the European Union. And there are four aspects, and I'll cover these a little bit. Personal value. And this means, does the care relate to the patient's personal goals, the problem that's bothering them most, not just to the diagnosis? Allocative value. Have we distributed resources across all populations and within each population group across all the groups? So have we allocated resources to people with respiratory disease or people with cardiac disease or people with mental health? And then within the respiratory allocation, have we got the right balance between COPD and asthma? Then there's technical value, and finally social value. How are we helping the local community? Now, technical value, just for definition, is much more than efficiency. And the American definition of value is outcomes over resources for the patients treated. But technical value means how we use the outcomes for all the people with back pain in our part of Singapore. Bearing in mind that people from the most deprived populations are probably less likely to get to the specialist service. So it's not just the efficiency of the spinal surgery service, it's what's happening to back pain in Singapore. Now, the other side of value is the word waste. And you can see here there are 4 different types of waste. Firstly, there's waste that you put in the waste paper basket. Secondly, there's waste due to low efficiency. Then there's waste when the outcomes don't matter to patients. So the hip replacement or the knee replacement might have been very successful from a point of view of radiology, but it hasn't actually solved the problem that the person called the patient, and I don't like the word patient, so the person called the patient brought to the health service. And then there's waste due to the use of resources that would give more value if you switched those resources for another purpose for that subgroup of the population. So, for example, switching resources from triple drug therapy by moving to double drug therapy and using those resources to increase smoking cessation or pulmonary rehabilitation in people with COPD. Or what would happen if you switched the resources to another segment of the population? Switching resources from COPD to asthma, for example, or from respiratory disease to cardiac disease, or from cardiac disease to respiratory disease. Now, at the moment, we haven't allocated these resources very thoughtfully. In most countries, the services have just grown, and I don't have the data, but I guess there's significant variation in Singapore between the 3 populations and the amount of money they spend on different segments of the population. So, here is the new agenda. We have to carry on with prevention, evidence-based decision-making, quality and safety, and increasing efficiency. But here's the new agenda, the 5-stage agenda. And I've had very good discussions with colleagues in Singapore about these. Firstly, population. So, we need to move from 2D healthcare to 3D healthcare. To be obsessed with the segments of the population. And if you're working for a supermarket, you wouldn't be worried so much about big supermarkets or small supermarkets. You'd be thinking about the balance between meat, fish, vegetables, alcohol, and the other offers that you've got. These are the eternal verities of healthcare. It's very important to think about self-care, informal care, primary care, secondary care, tertiary care. You have to have bureaucracies. Bureaucracies are very useful for linear tasks like the fair and open employment of staff, but we need to move to population healthcare. So when I look at this, I start to say, well, I wonder, here's a different way of looking at it. So as you can see here, I've made some changes. So it's from hospital in big letters to populations in big letters. Not only the 3 populations that you can see, but these segments of the population here. People with back pain, people with dizziness, people with type 2. And these are relatively simple segments of the population, but there's much more complex. So people in the last year of life, people with multimorbidity, for example, type 2 and heart disease and COPD, who in many health services go to see 3 different specialties. And then there's people with mental health problems and colon cancer. So here's what I see as population healthcare. When I look at your map, I start to think in this way. So here are sort of questions that we need to ask. And we cannot answer these questions yet in England if you take comparable populations. So is the service for people with seizures and epilepsy better than the service in NHC, better than the service in NUHS, for example? What do I mean by better? Well, what do you mean by better? What do people with epilepsy mean by better? it's something to do with outcomes, and it's something to do with the use of resources. Then there's a question there. How many liver disease services are there in SH? May just be one. You may just have one big liver service, but there may be more than one. There may be more than one network. How many should there be? Is it clear how many networks there are within the population? And I would ask, and I don't know the figures, and you may not know the figures, why is the expenditure on musculoskeletal disease greater in SHS than in another population? Why is it less? Was that a decision made on the basis of a study of need and unmet need? So, these are the questions that we ask when we think about population healthcare and not primary healthcare and secondary care. We still need to ask questions about quality and safety and efficiency of the services for the people who reach those services. We need to think in a different way. And when you move into population thinking, you start to look at allocation. And the clinicians have to take explicit responsibility for the balance between asthma, COPD, and sleep apnea. I'm just using this as one example. And then within COPD, shifting resources from triple drug therapy to smoking cessation and rehabilitation. All the resources. Do away with the distinction between primary and secondary and tertiary care. Now, secondly, we need to design a system for each population subgroup. And this is Oliver Williamson, who won the Nobel Prize for Economics in 2008. And he said that really complex problems cannot be managed by either bureaucracies or by markets, alone or in combination. What we need is the development of a system. And a system is a set of activities with a common aim and a common set of objectives. So, for example, people with type 2. Here's the aim. Then there are more detailed objectives. And these are the objectives that I got when we did work with a group of clinicians and patients. And I said they're very good. 5 out of 10. There are 5 other objectives we want you as a community of practice to adopt. And here they are. So we want the clinicians to take responsibility for the optimal use of resources. And this means we need a program budget. We need a budget for the total amount of money spent on respiratory disease, and within that, for the amount spent on COPD, asthma, and sleep apnea. And maybe we don't need so much detail about the money for the different diseases, but we can see rates of activity and have they got the balance right? Are they making the optimal use of resources? We also need to think about education of, say, pharmacy staff. What do they know about respiratory disease? And to take responsibility for mitigating the effects of deprivation. Having a map on the wall to show where poor people live and to monitor the rates of referral. And then at the bottom, to produce an annual report for the population served. Now, thirdly, we have to remember personal value. And this is the diagram we use for describing the evidence-based decision-making. The evidence is only one part of it. It's got to be personalized for this patient and to take into account the value this person places on the benefits and harms of the options and on risk-taking. Should they have the operation or not? Should they have the chemotherapy or not? So we need to make personal value part of our work, because personal value and population value are 2 sides of the one coin. Here you see the language that doctors use. Necessary, appropriate, inappropriate, and futile. As you put more resources in, you treat people who are less severely affected. And that means the benefit is less, but the harm is constant. The probability and size of harm is constant. So the balance of benefit to harm changes. And this reflects very much the same principle here, that population value and personal value are 2 sides of the one coin. We now need to move to working not through bureaucracies, but through networks. A network for people with inflammatory bowel disease. A network for people with Parkinson's disease. You need bureaucracies for the linear tasks, but we need networks. And then the fifth task, in some ways the most interesting, is to create the culture of stewardship and collective responsibility. And this is the other winner of the Nobel Prize. And she said, and she studied fisheries, she studied mountain pastures, use of water in Spain, that unless the people who use the resource are given responsibility for managing it, there will be what's called the tragedy of the commons. We'll just do more and more and more, and then the whole structure will collapse. We need to create a culture of stewardship. So thank you very much for asking me. I look forward to working with you. I always learn a lot from work with Singapore, and I hope this is the start of the development of value-based healthcare, which you've already done very good work on, but also population and personalized healthcare.
Well, thank you so much, Mer, for speaking with us this morning. And I think I speak for all of us when I say what an incredible parade of ideas. I will say when you started off by saying the future is not like the South Pole, I thought, oh, well, it is sort of cold, bleak, and expensive to get to. But I think what we've laid out here in terms of a path towards value-based care, I think is something that really resonates with all of us. I know we are very short of time. I just wanted to ask you one question. I thought it was terrific that you walked us through all of these principles, which for an economist are very near and dear to our hearts. But we ended up with this notion of the culture of stewardship. And what we know here is that we are at the start of this value-based care journey. I think most of us espouse the principles, but there are also some fundamental tensions when we bring this down to the ground and we speak to clinicians, simply because a lot of the perspective of clinicians has been very much about the individual patient in front of me. And the idea that I have a duty of care and the saliency of the collective impact of this or on resources seems very abstract at that moment. And so sometimes also when we talk about value-based care, I thought it was great that you showed that diagram about how value-based care is so much broader and more holistic than cost-effectiveness analysis. But very often when we say value-based care, people immediately respond as if we're talking about cost management. And that's a second barrier, I think, to the cultural change, which is that there is a knee-jerk response to some of these older concepts. Could you just say very briefly how you think, just in terms of changing people's minds or igniting this conversation, what can we do to get people to change that mindset, just in a sentence or two? What's the best way to inspire people to start thinking about value?
Well, the job of leadership is to change culture. And I can see in the audience when I saw the brief film, you are the leadership. All of you have to understand the new language about the 4 levels of value. We have to make sure that everyone understands that. That requires a training initiative to to rewire the brains of staff. And then I think one of the most important things is program budgeting. So we shift from just worrying about to the nearest pound. We know what every hospital in England spends, but we don't know how much is spent on, say, Parkinson's disease or neurological disease. We have to have the third dimension, 3D healthcare. And then we say to the clinicians and the patients, ladies and gentlemen, this is all you have. You can bid for more resources, but you are responsible for the stewardship of resources. And although I want you, when you're eyeball to eyeball with a person called the patient, to think of that patient, you've also got to appreciate that if you waste resources, other patients suffer. We're not interested in saving, we're interested in shifting resources from lower value activity to higher value activity. And only the clinicians can do that.
Perfect. Thank you so much, Mer. I think that's a great note for us to end this panel and this discussion, speaking about all of the different ways in which we've talked about redefining impact, making populations that are invisible visible, making impacts that are difficult to measure, again, visible, and here making the collective visible on the ground, not just in this very abstract way, but bringing it forward to the clinician in his practice, facing the person. I really loved, I think, in this talk that we don't speak about patients, but really persons with specific conditions. I thought that was a wonderful way for us to start this conversation. So thank you so much again, Mir, for speaking with us this morning, all the way from the UK. And to our audience, this is the end of segment 2 of today's conference, and I'm informed that before you go off, you should look for your Padlet once more, and think about your projects, taking into consideration everything that we've heard today. With respect to your KPIs, let's bring that word back. Your KPIs, are there new thoughts that you've had about how to measure impact, from whom to measure impact, and what types of impacts to measure, for example? Do you need to redefine the impact of your innovation in a broader way? And if you do, try to jot down a little bit of your thoughts about what you would do differently to deliver the maximum impact. So with this parting thought, ladies and gentlemen, it's my pleasure to be your segment host today for Redefining Impact. I've had a wonderful time up here inflicting myself on you. I wish you a very fruitful rest of afternoon. We will now go for an afternoon break, and please be back in the auditorium by 3:20 p.m. Thank you.